Yeah, right now.
Okay, I just want to let you guys know that we are live right now.
Great.
Perfect, yay.
So we might give everyone just like a minute or two before we get started. I see some people coming in.
Yeah.
Also, correct me if I'm wrong, but all of the attendees are automatically muted, right?
Yes.
So no one needs to worry about
No.
Yeah.
And they can't, no one, just for attendees who are here right now, you cannot unmute yourself. So if you have any questions, we'll cover this in a bit. You can drop them to us in the question and answer box.
And your video is not on or anything, so you don't have to worry about that. If you are eating or anything like that, you're muted and your video is not.
Tanya, one more thing. Can you make Trace Lane a panelist too? She'll be doing just a little blurb in the very beginning.
Sure.
And then with that, I think we have everyone we need.
Again, we're going to just give everyone another minute. We still have quite a few people joining in. So we just want to give one more minute to for everyone to get settled.
Quick question, is it Trace Lane?
Yes.
Okay.
We're going to go ahead and get started. Hi, guys. Thank you so much for joining us for the first of many talks in our series for Grad PIRATE Talks. My name is Emma Goldberg. I'm a fourth-year student in the PhD program in physiology, and I've been serving as one of 3 graduate student co-chairs, and alongside the graduate school, we've been working to create educational, conversational, and thought-provoking talks that not only raise awareness on how race, religion, gender identity, sexual orientation, and more affect the lives of our pirate nation and the nation as a whole, but these talks are also designed to challenge us all to take action against the inequities faced by our peers.
Yeah, and we're very, very excited about this. I can barely even contain it, how excited we are. But my name is Zoe Terwilliger. I'm a second-year PhD student in the biomedical sciences, physiology. I just want to go over a couple of formatting things for tonight. Before we begin, the agenda, kind of a rundown of what we're going to do is some brief introductions, and then we have a couple of students with us here tonight that will give a couple brief statements about some recent news that has kind of hit our feed. And then I'll turn it over to Chris in a second, who will read a land acknowledgement statement that we think is really important from SGA and the Office of Equity and Diversity. And then if you have any questions or comments or concerns throughout the program or at the end, please just put them in the Q&A box, and we will work to facilitate those questions to the panelists after the talk is concluded. With that, Chris. Chris, you're muted. Sorry. Working with WebEx.
That happens, yeah. All right, start over. Hi, everybody. My name is Chris Rickson. I'm a second-year master's student in sociology. And tonight I will recite a land acknowledgement statement that was adopted by ECU SGA a while back. It is important to remember that this land was stolen and that colonization is an ongoing process, and therefore we must take steps to bring forgotten histories into our shared collective consciousness. We acknowledge the Tuscarora people, who are the traditional custodians of the land on which we work and live, and recognize their continuing connection to the land, water, and air that Greenville consumes. We pay respect to the 8 recognized tribes: the Coharie, Eastern Band of Cherokee, Hala Saponi, Lumbee, Meherrin, Okinichi Band of Saponi, Saponi, and Wakamas Soan, all nations and their elders past, present, and emerging. I now pass the floor to Trace Sykes, a member of the Pirate Initiative Committee, and to Josiah Thornton, the SGA Director of Equity and Intercultural Affairs, to reflect and respond to the recent stance taken by the U.S. administration.
And a brief interruption before Trace and Josiah kind of hop into these very, very important statements that they've decided to make. We do have an interpreter for anyone that should need, or anyone that is hard of hearing. Her name is Teresa Loft, and if you could just pin her to the top of your page, she should show up the entire presentation to help. And thank you so much, Teresa, for being here. We really, really appreciate it.
And with that, we hand it over to Trace.
Thank you. Hi, everyone. My name is Trace Lane, and I'm a PhD student in the Integrated Coastal Sciences program here at ECU. As a hydrosocial scientist in training, my research explores the human dimensions of climate change from perspectives rooted in social justice, intersectional epistemologies, and feminist frameworks of knowledge. I'm proud to join my colleagues in building a more inclusive pirate nation. We're pursuing anti-racist, intersectional learning, dialogue, and action steps. We're building a more inclusive ECU and a community of engaged allies. It's my belief that in this particularly dark moment in our nation's history, that it is incredibly important to lean into social justice, not away, and to understand that these ideas are American. This is what we're here to do. I'm excited to pursue this work as a learner, as a laborer, and as an ally. Thank you.
And our next statement is going to be from Josiah Thornton.
Hello, everybody. My name is Josiah Thornton. I'm the current newly installed and appointed Director of Equity and Intercultural Engagement Committee for SGA here at East Carolina University. And I do want to say thank you for having me on this platform. And I will give my statement. The Equity and Intercultural Engagement Committee is tasked with supporting all students' ability to live, learn in the East Carolina University environment, regardless of age, gender, race, color, ethnicity, national origin, religion, creed, political ideology, political affiliation, political party, disability, veteran status, sexual orientation, gender identity, gender expression, or genetic information. Our committee will collaborate with all campus departments and student organizations to ensure a variety of programming and support exists on campus that represents the diversity and the fairness of the student body. I do want to also say, in this unusual new time we live in today, in this new normal, that with all the different administration from the White House rhetoric and different propaganda that's going on, in the recent ban of training, I will say that it's very divisive. You know, it is very, very, very misinterpreted, it's misaligned, it's misimplied. The current administration right now has a long way to really correct itself. Will it get there? I don't think it will. In this era that we live in of politics, race politics has come about more and more and more. You know, we live in an era where microaggression is now the new normal. And with that being said, I stand in solidarity with Zoe and also Emma and the grad students and their Grad PIRATE Talks and in their initiatives and campaigns to denounce, deny, and denullify all outward injustice, bias, hate, and racism. Thank you so much.
Thank you so much, Josiah and Trace. We so appreciate having you here, and we appreciate everything that this committee is working to do.
So over the past few months, we've had the privilege and the honor of working with students and faculty that span across ECU's campus, from health sciences to the main campus. And tonight's talk is going to be presented to us from 3 third-year students in Brody Medical School, Amber Priester, Jacqueline Poston, and Keisha Craig. And we've been working with Amber and Jacqueline and Keisha this whole time. So they've been with us since this committee was formed. So they've really been great, and they've helped us so much in learning, and we're so excited for their talk. And they're going to be joined by Dr. Cunningham, and they're going to be presenting to us some racial disparities in maternal fetal health. And with that, we will pass it over to our speakers, share their presentation with you all, and we hope you enjoy.
Please put questions in the Q&A box as you see fit. We'll kind of screen through them and post them at the end.
Just give us one
quick technical second. Tanya, we lost the ability to share. Do you know if we could get that back? Sorry, everyone. You know, working in the new WebEx age of things, we're learning.
We are but humble scientists.
Definitely not computer scientists, obviously.
Got it.
Thank you, Tanya.
You're
All right, good evening, everybody. My name is Amber, and this evening I'm joining 2 of my wonderful classmates to talk to you about the health disparities that disproportionately affect Black mothers and their babies in the United States. As future physicians, our hearts ache at the pain and suffering that our Black patients disproportionately endure. And we're frustrated and outraged at the dire health statistics of Black moms and their babies. And we hope that tonight we can share some of our knowledge and our passion for this topic with you. Next. All right, so let's start off by talking about some of our goals for this evening. We're going to define some of that terminology we'll use, and we're going to talk you through some of the medical causes of maternal and infant mortality and morbidity. That just means death and serious disease. We're going to present those maternal and infant morbidity and mortality statistics to you, and we're going to have a particular focus on the racial disparities that are embedded there within them. Then my classmate, Jacqueline, is going to identify some of the mechanisms by which those healthcare disparities exist, talking about things like barriers to care and other things that keep Black women from having the care that they deserve. And then finally, we aim to inspire our listeners, that's you, to think about ways in which the ECU and Greenville community can alleviate this issue. Next. All right, so let's talk about some of that terminology that you might hear us say tonight. So when we say maternal mortality, we're just talking about the death of a woman anytime during pregnancy or within 42 days of delivery. Now, the reason we include those 6 weeks postpartum is because some things that kill mothers that are directly related to her pregnancy don't really manifest themselves until after the baby's born. This might be delayed hemorrhage after birth, or it might be a pulmonary embolism a few days after. So fetal mortality just refers to the death of a fetus, that means they're still in mom's uterus, between 20 weeks of gestation or pregnancy and the time that they're born. And then when we say infant mortality, we're just talking about the death of a baby sometime after they're born, but sometime before their first birthday. All right, so let's talk about some of the top causes of maternal mortality, which again just means maternal death during pregnancy or within the first 6 weeks after she delivers. So the top cause worldwide is obstetric hemorrhage. That just means bleeding out during delivery. The second cause worldwide is hypertensive disorders, and this includes things like preeclampsia and eclampsia. These are serious conditions that can lead to stroke and seizure and other life-threatening complications. Up next, we have sepsis, which just means a severe body-wide infection. Next comes abortion. Now, this is twofold. It can be talking about elective abortions, and it's more common for women to have complications that are possibly life-threatening if she doesn't have access to safe, legal, and affordable abortions and is forced to go down unsafe routes to get that abortion. It's also talking about unintended miscarriage because the medical term for miscarriage is abortion. And fifth, to round out the list, is embolism. This could be something like a pulmonary embolism where mom has a blood clot in her leg and it breaks off and travels to her lungs. Now, these make up about 75% of the causes of maternal deaths worldwide. And it's important to look at number 2. Number 2 is hypertensive disorders like preeclampsia and eclampsia. And guess what? Black moms have higher odds of entering pregnancy with pre-existing hypertension already. And even if they didn't have hypertension before, they have higher chances of developing preeclampsia during that pregnancy. And that's the number 2 killer of moms worldwide. So let's go into talking about some of the maternal complications that, while it might not kill moms, it could be devastating for her for years and decades to come after delivery. So gestational diabetes just means diabetes that starts up during pregnancy. It usually goes away after mom delivers her baby. But even if it did go away after she delivers, it sets her up with a long-term risk for developing type 2 diabetes, which, as you may know, type 2 diabetes can lead to long-term nerve, vascular damage and infection. And it's important to note that Black moms have a 63% higher risk of gestational diabetes than white mothers. Up next, let's talk about postpartum depression and anxiety. So this is a really serious complication, and a lot of women don't know how common these symptoms are after delivery. And because of the stigma associated with mental health, which is especially compounded by the fear of being seen as a bad mother, a lot of women don't talk to the women and men in their life, and they are afraid to talk to their doctors. And guess what? When you ask Black women about symptoms of postpartum depression, if they are actually asked by their provider, they're more likely to report symptoms of postpartum depression. Finally, we want to talk about pelvic floor dysfunction, because this is a serious cause of debilitating embarrassment to women and shame. So the pelvic floor is just the muscles and ligaments that hold all of your pelvic organs up in place. And when they get weak after, say, a mom has delivered multiple babies, some of the organs in the pelvis can start to sag out. And this might lead to things like urinary incontinence, which just means mom might dribble a little bit of urine when she laughs. That's embarrassing, and it can be very shameful. Also, moms can have something called uterine prolapse, which, can we click next? So if you look at the picture on the screen, this shows a uterus that is seeming to fall out of the mom's vagina. As you can imagine, this can be really embarrassing, really painful. It can cause pain during intercourse. It can cause pain while sitting. It can keep a mom from pursuing her career or going out with friends or having an intimate life. So these are just debilitating and devastating complications of pregnancy. And so many women, especially in vulnerable and marginalized communities, don't know about these complications, and they're scared to talk to their doctors. All right, so let's move on to the top causes of infant mortality in the United States. So as a reminder, infant mortality is just death of a baby sometime after they're born, but before their first birthday. So the top cause overall in the United States is congenital malformations and chromosomal abnormalities. So these are things that might be genetic, they might be environmental, or sometimes, usually, they're a combination of both. Number 2 in the United States is low birth weight or prematurity at 17%. However, this is the top cause of death in African American infants. So let me repeat that. African American infants are more likely to die from low birth weight or prematurity. That doesn't mean that they're less likely to die from that they're less affected by congenital malformations or chromosomal abnormalities. It just means that they disproportionately bear the burden of low birth weight and prematurity. And we know that the causes of low birth weight or prematurity are multifold. So this could be things like smoking, obesity, mom's past medical history complicating the pregnancy. It can also be things like life stressors. Say if a mom has food insecurity or housing insecurity. It can also be linked with the stress of chronic exposure to racism and chronic exposure to microaggressions, such as our Black mothers face. Next. So let's talk about some of the complications that can affect the lives of babies. These can be life-threatening. They can cause stays in the NICU. So just a lot of things that can complicate a baby's life in the first year. So when a mom has type 2 diabetes or gestational diabetes, their babies are at risk for something called hypoglycemia, which just means low blood sugar. Now, this can be rapidly fatal, so it involves a lot of acute management. Baby might have to go to NICU. So there's a lot of resources that go into managing these babies because it can kill them very quickly. Now, babies who are born to diabetic mothers tend to be a little bit larger. And I know we just talked about how Black mothers are more likely to have babies who have a lower birth weight, which can be dangerous. But having a large baby can also be dangerous too. If you look at this picture on the screen, this is showing something called a shoulder dystocia. And a shoulder dystocia just means that baby's shoulder gets stuck under mom's pelvis as the baby's trying to exit the birth canal. Now, usually this is no problem. We do some maneuvering and baby comes out just fine. But sometimes it can break baby's bones or it can cause nerve damage. And sometimes that's permanent. So some babies can be left with a permanent paralysis of one of their arms. Finally, large babies who have difficult deliveries sometimes require help getting out. And doctors are forced to use tools like forceps and vacuums to help assist the baby to get out of mom's body. Now, these are wonderful tools. The doctors are right to use them to assist the baby getting out. However, they do come with some risk for trauma to the baby. And as you can guess, Black mothers have a 63% higher risk of gestational diabetes than white mothers, which means their babies disproportionately bear the burden of all of these complications that I just went through. The low blood sugar, the large size, the shoulder dystocias, the trauma from having to be assisted during delivery. Let's move on to talking about the problems stemming from premature birth. So premature babies can often be born with breathing problems, and this is secondary to their immature lungs. Lung development doesn't occur until pretty late in pregnancy. Babies who are born premature can have heart murmurs and heart defects. They can have vision and hearing loss, and this can be permanent, unfortunately. They can have brain bleeds or hemorrhage, which can be devastating. They can also have long-term behavioral and psychological problems, such as depression, anxiety, ADHD, and even developmental delays. And just a reminder, Black infants are more likely to die from prematurity and low birth weight. That's the #1 cause of death among African American infants in this country. So now I'm going to hand it off to my classmate, Kiesha, who's going to talk to you some more about those statistics.
Hi, so I'm just going to give you a little rundown about the statistics regarding racial disparities in maternal and infant health. So prematurity and low birth weight accounts for 33% of all Black infant deaths. Prematurity and low birth weight, those same two things, only accounted for 21.2% of white infant deaths. The top cause of death in Black infants is prematurity and low birth weight. The top cause in white infants is congenital malformations and deformations. So I really want everyone joining us today to think about that last statistic. Black infants are dying because of prematurity and low birth weight versus congenital malformation of white babies. This points to a lack of adequate prenatal care offered to Black women being one of the biggest contributors to health disparities experienced by Black moms. This is followed by a lack of support, a lack of care or support from our healthcare system. Next. So when looking at infant mortality in Pitt County, between 2014 and 2018, there were 22 non-Hispanic infant deaths versus 73 Black infant deaths. In the year 2018, there were 0 non-Hispanic white deaths versus 11 African American infant deaths. So I just really wanted to stress that these statistics are from Pitt County. So we are facing the same problem in our community that is prevalent in the US as a whole. Next. So when looking at maternal morbidity or maternal mortality as a whole, more American women are dying of pregnancy-related complications than any other developed country. The US is the only developed country whose maternal morbidity has been rising over time. Other countries, such as the UK and Germany, have seen a decline. Next. So this table presents examples of key disparities in OBGYN health and healthcare. When looking at disparities in health outcomes, Black women have a higher incidence of preterm births, fetal deaths, and maternal deaths when compared to white, Asian, or Hispanic women. Next. Also, birth control was provided to white women more than Black and Hispanic women, and prenatal care was provided to white women more than Black and Hispanic women. Next. So this table presents maternal morbidity when compared with the highest level of education obtained by the mom. So again, maternal morbidity is just the death of a woman during pregnancy or within 42 days of delivery. So when looking at this graph, the bottom axis shows the level of education achieved by the mom, with the side axis representing maternal morbidity. The most important aspect of this chart I wanted to point out is that there is higher mortality despite increasing education. Black non-Latina moms with a college degree or higher, which is the orange bar on the far right of the graph, had a higher maternal morbidity rate than white non-Latina moms with a less than high school education, which is the yellow bar on the far right. To state it in another way, Black women are dying at a higher rate than all other races and ethnicities of moms, no matter the education level they obtain. So to sum it all up, Black women are 2 to 3 times more likely to die from pregnancy-related causes than white women. For me, that these statistics support that disparities in maternal and infant mortality are rooted in racism. Structural racism in healthcare and social service delivery means that Black women are often receiving poor quality care than white women. It means denial of care when Black women seek help when enduring pain, or that the healthcare and social service providers fail to treat them with dignity and respect. So all of these stressors combined and the experience of racism and sexism during pregnancy can cause a long-term psychological toll that puts African-American women at a higher risk for a range of medical conditions that threaten their lives and their infant lives. Next. So when looking at mental health, mood and anxiety disorders are the #1 complication of pregnancy. 50 to 85% of women experience baby blues. In high-income countries such as ourselves, 7 to 15% of women suffer from antepartum depression, which is depression before birth, while 10 to 15% of women experience postpartum depression. And these statistics are even higher in low and middle-income countries. Next. So some of the factors associated with postpartum depression are physical symptoms of pain, lack of social support, food and housing insecurity, and healthcare access. 43.9% of Black women reported postpartum depression versus only 31.3% of white women. This signifies that postpartum depression it basically affects Black women a lot more than white women. Next. And now I'm going to hand it off to my classmate, Jacqueline.
Hey guys. So I'm going to start talking to you a little bit about some of the barriers that patients face. We've talked about the different complications that Black moms and babies experience at a higher level compared to white moms and babies. And we've also shown some of the really scary and horrifying statistics demonstrating racism within the context of maternal and infant health. So now I'm going to talk to you guys about different barriers that Black women face at a disproportionate level compared to white women. These barriers can lead to all of the complications that Amber discussed earlier. So the first section highlights the barriers that Black women face at the patient level. Basically, these are all of the barriers that the patient herself could come into contact with. So starting on the right, Black women are less likely to have access to care in general. Black women are also less likely to have a job that will allow them time off for healthcare appointments. And lastly, Black women are less likely to have access to childcare to watch their other children while they go to the doctors for their future baby. So you can see that all of these barriers would set the stage for Black moms to have complications down the road. Moving on to the left side, Black women are more likely to receive delayed care. This could be because they may be located farther from the facility, as well as having poor or no access to transportation. Next, Black women are more likely to have unintended pregnancies compared to all other racial groups. So there are several reasons for this. Black women are less likely to have health insurance, which means that they are also less likely to have a form of prescribed birth control, such as birth control pills or an IUD. They may then use other forms of protection, such as condoms, but it is known that these forms are not as effective. Another reason why Black moms are more likely to have unintended pregnancies could be due to the fact that there's less patient education for Black women when it comes to pregnancy, birth control, etc. Unintended pregnancies in and of themselves, regardless of race, are associated with increased mortality for mother and baby. So the last point that I want to make about unintended pregnancies, is that usually when patients have unintended pregnancies, they're not going to seek care until the second trimester. And so not having care in the first trimester sets the scene for their baby to not be as healthy compared to white baby counterparts. So moving on to the next point, Black women are more likely to experience stigma around pregnancy. And stigma is defined as social disgrace or disapproval. Compared to white women, Black women are more likely to report that they experience stigma around pregnancy, and they're more often shamed for pregnancy in different ways. Due to this stigma, Black women are less likely to seek out adequate care for themselves and their baby. Last but not least, Black women are more likely to experience chronic stress by simply being a Black woman. I will elaborate on this in the next slide. Okay, so Black individuals undoubtedly experience chronic stress by simply being Black in America, and this most definitely translates to Black women during their pregnancies. Next. Research shows that the chronic stress of being a Black woman in American society can take a physical toll during pregnancy and childbirth. Next. A professor at the University of Michigan School of Public Health coined the term weathering in 1992. Weathering refers to the idea that chronic stress can cause wear and tear on the body. An example of this is the phenomenon that occurs when we're under a lot of stress. We are more likely to catch a cold or get sick. I know I've experienced that when I'm under stress for like a short amount of time. But Black individuals experience early health deterioration as a consequence of the additive impact of experience with social, economic, and political marginalization. Simply put, the stress of living in a race-conscious society that stigmatizes and disadvantages Blacks can cause disproportionate physiological deterioration of Black bodies. Next. So studies of weathering have shown that Black individuals have an increased susceptibility to infection. Next. That they have an earlier onset of chronic diseases, particularly hypertension and diabetes. And it's already known that hypertension and diabetes affect Black individuals at a much younger age than white individuals. So this translates to the idea that a Black individual may show the mortality and morbidity typical of a white individual who is significantly older. That is, in the US, Black individuals may be biologically older than white individuals of the same chronological age due to the cumulative impact of repeated exposure and high effort coping with stressors. So this next point is pretty shocking. If you want to click next. Research shows that the DNA in the bodies of Black women is biologically older compared to white women of the same age. And this is arguably due to the chronic stress and weathering that Black women face on a daily basis when compared to white women. Next. So now that we've defined what weathering means and talked about how it can affect Black individuals, let's dig a little bit deeper into how weathering can affect Black women during their pregnancy. Long story short, chronic stress experienced by a Black woman leads to stressors and ultimately leads to preterm birth. So the things that Kiesha and Amber were talking about earlier. And Black women actually are 49% more likely to deliver a premature baby compared to white women. Furthermore, Black infants are twice as likely to die before their first birthday. Again, it does not matter how much money a Black woman makes, and it does not matter how much education she has. A very educated, high-income Black woman still has a higher chance of delivering prematurely and still has a higher chance of having a baby that's more likely to die before their first birthday. These statistics should alarm you. As Kiesha mentioned earlier, these statistics highlight that there's undoubtedly racial disparity in issues rooted in racism. Next. So we've talked about how Black women face barriers on an individual level, and now I want to talk to you about barriers that Black women face at the healthcare system level. These large factors occur on a community, state, or nationwide level and go to impact individual patient care. Starting on the right, Black women are less likely to have insurance. They're also less likely to have access to quality contraception care and counseling. I don't know how to respond to that. Oh, sorry. Okay. They're less likely to have access to quality contraceptive care and counseling. For example, in a recent analysis of Californian women enrolled in Medicaid, Black women were less likely than white or Latina women to receive postpartum contraception. And when they did receive it, they were more likely to receive a less effective method. So to touch on this for just a second, postpartum contraception is some form of birth control that a mom uses after she gives birth to a baby. And it's used to prevent unintended and closely spaced pregnancies in the first 12 months after giving birth. And postpartum contraception is particularly important as pregnancies during this period of the first 12 months after a birth hold the greatest risk for mother and baby. Next. So moving on to the left side, Black women are more likely to have increased cost of care. And this goes back to the fact that Black women are less likely to have health insurance. Next. Secondly, Black women are more likely to give birth at hospitals that serve predominantly Black populations. In fact, 75% of Black women give birth at hospitals that serve predominantly Black populations. So what does this mean? Basically, Black serving hospitals are known to provide lower quality maternity care, and Black serving hospitals have higher rates of maternal complications than other hospitals. They also perform worse on 12 of 15 birth outcomes, including elective deliveries, non-elective C-sections, and maternal mortality. So digging a little deeper, why do Black hospitals have higher rates of complications? Well, one reason is that they are located in areas that are often the products of historical segregation. This means that these hospitals are typically lower in quality than those where white mothers deliver. This is due to less funding, fewer resources, and a long history of segregation, as I said. Lastly, next, Black women are more likely to experience implicit bias. And I'll talk more about this on the next slide. Next. So what is implicit bias? Some of you may have heard of this term before, but some of you may have not. So implicit bias refers to when we have attitudes towards people or associate stereotypes with them without our conscious knowledge. Next. One example is that studies have shown that white people will frequently associate criminality with Black people without even realizing they're doing it. Next. So every single person, regardless of race and regardless of what you feel, where your state of mind is, every single person has implicit bias towards other group of people. And being able to understand this is something that we all struggle with, and it's the first step to addressing the problem. Next. So how can implicit bias affect patient care? Next. Providers can unconsciously treat Black women and Black patients differently, which leads to worse health outcomes for Black moms and babies. All of the complications that Amber discussed earlier apply here. Next. In a survey conducted this year by NPR and the Harvard School of Public Health showed that 33% of Black women said they personally had been discriminated against because of their race when going to a doctor or health clinic. Furthermore, 21% of Black women have avoided going to a doctor or seeking health care out of concern that they would be racially discriminated against. So this is pretty alarming and not acceptable. These statistics should make you feel uncomfortable, and they should make you feel alarmed because they have very extreme impacts. If Black women don't go to the doctor simply because they know they will be racially discriminated against, this already sets Black moms up for complications for themselves and their babies. Next. So Black women, so these problems are amplified by unconscious biases that are embedded in the medical system, and this needs to change. The next point is that Black expectant and new mothers frequently say that doctors and nurses didn't take their pain seriously. This idea of not believing Black patients is shown in numerous studies that show pain is often undertreated in Black patients for things such as appendicitis all the way to cancer. So lastly, we have the idea of victim blaming. Victim blaming occurs when the victim of a horrible act is held entirely or partially responsible for the harm that fell on them. This occurs frequently to Black individuals in many aspects of society. But in particular for Black moms, they will be blamed for the death of their baby when providers say things such as, if only she would have done this, or if only she would have understood that, or if she did better at treating her hypertension, then she would not have put her baby in danger. So these thoughts that blame mom rather than addressing the underlying issue of racism and implicit bias only go to continue this horrible cycle. Next. So I want to leave you guys with this quote from an expecting Black woman in Brooklyn. She says, sometimes you just know in your bones when someone feels contempt for you based on your race. So that's pretty powerful. And it goes to show that these impacts can stem from our unconscious biases, which hold more power than we think. Next. Okay, so now it's my honor to present our guest speaker, Dr. Cunningham. Dr. Cunningham is a clinical assistant professor of the Brody School of Medicine, and she's also the vice chair of diversity and inclusion at Brody. Dr. Cunningham works as a licensed clinical psychologist and health services provider here in Greenville. Today, we're honored to have her share her story and experience of being a Black woman and mom-to-be. Dr. Cunningham, thanks for joining us.
Thank you so much. When I was asked to talk a little bit about my experience, I kind of thought back. I'm like, well, things happen, but it's not like I'm still here. I'm still alive, right? My complications were able to be kind of taken care of. I don't know if they necessarily need to hear my story. But as I continue to kind of talk through and think through, I felt that, okay, well, I think this is a good opportunity to be able to talk through, even when you kind of do everything by the books, things still come up. And just for context, I do research in sexual and reproductive health, and I work with moms a lot of the times. And at the time I was pregnant, I was actually working in women's and infants, which was our main hospital in Providence where I was practicing and training at the time. And I knew I wanted to get pregnant. I knew that it was the perfect time to get pregnant in the part of my training. I had just gotten off internship and I knew that I was going to have time. So I met with my OB, and so my obstetrician and my gynecologist, and says, hey, I want to be able to get pregnant and I want to be able to do it within this time frame. We talked through through my whole history as to what it is that I should be kind of taking care of. For context, we've talked about some of the pre-existing conditions that can have impact. So I've had hypertension since I was 18 years old. And so it was something that, again, I went to my doctor as a regular follow-up. They took my blood pressure and it was sky high. And they thought it was really unusual for my age to have hypertension. And they did all the workups possible. And they kind of came down to it, just says, well, it must be just genetic. We kind of work with it. And then that was the one thing that I really wanted to make sure I got everything kind of taken care of. And so I was able to follow all my doctor's instructions and I got pregnant and I was really excited. And I went to every prenatal appointment and I talked about all the things that I was feeling. But I also noticed that there were some things that weren't going as they were supposed to. Like I said, I was in the hospital that I later delivered in, and the clinic that I was going to was actually right behind the hospital, and we had a really good relationship with them. And in that practice, which is common at many OB practices, is that when you're pregnant, you will meet many of the physicians within the practice because they didn't know who was going to be on when you delivered. So you would have a primary doctor, which I had, again, carefully selected who would be, but then I started to meet the other people in the practice. And as you go through your maternal care, you find that you're supposed to be going through specific blood work. They're supposed to be telling you the results of those blood work, and they're supposed to be kind of moving things through. And I notice, again, I get my lab slip and I see the things that they are testing me for. And I get those tests done. And I realize they're not telling me the results of my tests, right? They're not calling and talking to me about some of the things, or if they do tell me something, they're skipping over specific ones. Again, I work in sexual and reproductive health, and I particularly, one of the tests that are supposed to be, done is for, say, like an HIV test or STI, so sexually transmitted infections. And they didn't go over those, even though they tested me for it, right? And they're supposed to do that. And so I call them out and I say, well, actually, you didn't give me my results about this. Oh, no. We don't give results about, those sort of things. We don't talk about, you're going to do a test, one that, if I didn't look at it, I didn't know that you were giving me this test. Why didn't you tell me about it? Like, you're supposed to do those things. They're like, oh, well, it's just something that's kind of routine. We don't have to talk about it. I'm like, okay, cool. Maybe that's just their practice. If it's not positive, they're not going to talk about it, or they won't send you a letter. Fine. Then I started noticing that I started feeling really unwell. So I would get very dizzy. I would start to have a lot of kind of pain. And I would go into my regular visits, and again, rotating through the different providers. And I'd be like, I'm feeling a lot dizzy, just really dizzy all the time. And I'm feeling, a lot of pain in certain areas. And, I'm actually feeling stuff in like my throat, and I don't know what's kind of going on. Oh, well, that's completely common. You can have dizziness, you can have it. It's nothing to, nothing to worry about. Everything looks fine. I'm like, well, how do you know everything looks fine? Well, none of your labs are alarming. I'm like, okay, but I'm telling you I'm feeling unwell. And so this went on for another couple of weeks. And during that time, I was actually working, in my lab, essentially. And I was in my cubicle, and I was typing away on a grant at the time, which some of you guys might be familiar with working on. And I was sitting, and I passed out. I fainted. And I got back up, and I was like, what happened? Thing, went to my doctor and kind of got things checked out. And, they told me that, oh, well, you probably just, your blood sugar might've been a little low. Like, it's another thing. I'm like, no, I've been dizzy for weeks. I'm passing out. I have this pain. Like, what is happening? And at that point I got pretty fed up. During that time, while they're telling me that everything should be fine and everything is everything, they did start saying that I was gaining too much weight for my pregnancy, and maybe that had something to do with it. Mind you, so prior to my pregnancy, was a yoga instructor, a weightlifter, and so my overall body mass index is kind of, so the ratio that people look at your height and your weight is actually kind of misleading. And then I put on additional weight. Mind you, I was still practicing yoga 4 or 5 times a week, and was a part of a yoga photo shoot at that point for prenatal yoga. So still very fit, right, for my body type. But they're like, nope, that must be it. You're putting on too much weight. It must be what's kind of going on. And so I was like, no, I'm done. So I switched to a different provider. I went to a different clinic that was more closely associated with my fellowship. And I went in there, and again, they knew me from walking around in that clinic and talking to them. And the first thing that I asked for is like, I need to go to a specialist. Something is happening. Something is going on. My last OB was not helping. They totally disregarded my pain, and they totally disregarded, I was fainting. I'm still having this dizziness. What's going on? And so within that first visit, I was sent to a maternal fetal specialist to be able to set things out. Now we're at about 24 weeks. And at that visit, the specialist did a lot of tests, ran additional blood work, did a very thorough. And during that exam, she felt, like there was a lump in my throat, right? And she said that, this, has anybody noticed this before? I'm like, well, everyone has palpated, everyone has touched that area. And no, no one's actually said anything. She's like, okay, well, it's probably nothing. well, I'll go send you for an ultrasound. And so they went and they did an ultrasound, and they're like, oh, well, we need to do a biopsy. I'm like, okay, again, it's probably nothing. Like, okay. And I was like, well, do you think that this is what's maybe going on? Is this something that could be causing changes? It's like, well, we saw some abnormalities in your blood work, which is not typical for what we think this might be. But we actually think that some of your dizziness actually had to do with your baby's positioning and was actually kind of cutting off blood supply. And so that was what was causing some of the issues. And I'm like, okay, so it should be fine. And I told her, I'm like, hey, I'm about to leave the state or leave the country for my baby moon. And we talked about the precautions for like viruses that were going on at that time. And she said, sure, I'll call you with the results. And lo and behold, when I was about 29 weeks, I was in St. John on my baby moon, and my doctor called and told me I had cancer. And so, that was really just startling, right? That this is potentially what was kind of going on. And, she said that it possibly had been changing, like during pregnancy. I had thyroid cancer, which again has great survival rates, no matter kind of when things happen and that kind of stuff, which is always the thing that they kind of lead with, right? They're like, well, we don't think that it had major impacts kind of early on, but it may have started to have some, because the size is larger than what we expected. And we're actually thinking that your thyroid was kind of dysfunctional at that time, and so it was actually impacting some of the things with weight gain and some of the other aspects that were going on at the time. And so, but because of the time that we are finding it, now that you've entered your third trimester, we are going to actually have to delay your surgery until after you deliver, right? And so that was pretty hard to kind of hear in terms of being able to get into treatment. And so we went through things, and my blood pressure started to react. My blood pressure had been great throughout most of it. Started to have more difficulty controlling my blood pressure, which actually led them to induce me at 39 weeks. And so I went in for a planned induction, and we delivered, and that was somewhat disorienting because during that time, my son, whose name is Kai, he had what they call some decelerations and desats. So his heart rate was going down often during the induction. He wasn't tolerating the delivery very well. And so they continued to kind of check in and kept telling me that they were likely going to have to take me in for an emergency section because of what was kind of going on. But we were able to kind of tolerate, and we delivered. And when he came out, one of the reasons why he was having these changes is because he had what they call a nuchal ×2. So his umbilical cord was wrapped around his neck twice, and there was a true knot in his umbilical cord, which having it wrapped around once, that happened twice. That's kind of unusual. Twice plus a true knot, highly unusual for that to kind of happen. And it should have been something that should have been caught previously on ultrasound, and it wasn't. So if they had known that they wouldn't necessarily have gone that way, because it significantly increases his risk of death, during that kind of thing. And it accounts for some of the reasons why we're having some complications. So that was hard. I often kind of think back as if I hadn't switched providers, if I hadn't asked for additional kind of services and specifically requested a specialist and that additional workup, I wouldn't have known I had cancer. I wouldn't have been scheduled for surgery 2 weeks after my delivery. I wouldn't have taken about 6 months for recovery and additional treatment. All of those things in the context of my pregnancy, which was already really hard. So next slide. So like I said, I work in this field and I work with mamas all the time. And I think one of the biggest things that I run across is mamas really being able to fight and feeling like they have to continue to be fighting to be understood. And so some of the time I hear from different providers when they're talking about some of the moms that I'm working with, and they say things like, I don't know why she won't talk to me, medical provider, and that kind of going off of this idea that there's this mistrust. But when you talk with that mom, she tells you things like, well, of course I don't trust this provider. They don't tell me anything, or they continue to blame me, or I've had my rights taken away at different points in time, and I'm being very cautious. There's oftentimes this kind of being accused or feeling of being accused of not following medical advice. So one of the nurses that I had worked with in the past, talking about a patient said, she won't agree with anything, even if it would save her life. And again, talking about a patient who is trying to follow medical advice, trying to do everything that she can for both herself and her baby, but there are so many other impacts, other things that are going on that are keeping her from being able to, like not having electricity to be able to run things like a nebulizer, so a machine that helps with the breathing treatment for lung issues. And so if you don't have any electricity and you only have an outlet powered nebulizer, then you can't do this treatment. And no one took the time to be able to kind of try and find out. Maybe then even kind of thinking about the terms of consent. So moms get to have the choice if they want a procedure or not, but sometimes that choice is kind of taken away. And the providers are very forceful in saying things like, we need her to let us do the C-section. She is such a difficult patient, because the patient's unwilling to consent for a treatment they think is needed. But what if for that mom specifically, that last time she had a C-section, her baby died? And these are some of the stories that we kind of work with. And, it's not her being a difficult patient, it's her having trauma related to following the directions of someone and not having the outcome that she wants. And so when we don't kind of consider and think about these other aspects, or be able to take a step back and watch where our emotions as sometimes clinicians, providers, families, friends, or what we're providing to other people, we're causing harm. And this is definitely something that can happen to any mama, but specifically for our Black and Brown and Indigenous mamas, this happens more often, right? And it's just not fair.
Next. Thank you so much, Dr. Cunningham. We really appreciate you sharing what you had to say tonight. So, during this presentation, we've presented information to you all about maternal and infant morbidity and mortality in this country and in this county. We've presented some of the possible barriers to care that non-white and impoverished mothers may face, keeping in mind that each woman's experience is unique. So you've gotten to hear from Dr. Cunningham, like we said, who is a fantastic resource due to her background in psychology and behavioral medicine, in addition to her experience as a mother. So we hope this presentation has been informative and it has opened your eyes to some of the issues that Black moms face in this country. We hope that this will make you think critically about women in your lives, practices, and communities. Even celebrities are affected by these health disparities. I don't know if you all have heard about the story of Serena Williams, who had the pulmonary embolism after delivery and received delayed care. So these issues, they don't care how much money you make, they don't care how much education you have, they will affect all Black women. And as future physicians, Kiesia, Amber, and myself, we've all decided to make a pledge as we move forward in our learning and in our careers. So I encourage you guys, all of the listeners as well, to kind of think about pledges that you can make that will fit into the context of your lives as well. So I will start. I will say that I pledge to continually educate myself on my own implicit biases so that I can face them head on, to ensure that I give my Black patients the care they need and deserve. So that's mine. And next is Kiesia.
So for me, I pledge to help improve access to care for pregnant Black women, and I will do this by offering tools and support in navigating the healthcare system by focusing on patient education and talking to the patient rather than at the patient. And Amber, you can go.
Yeah, and finally, my pledge is to listen to all of my patients. But I realize it's not enough to just say I'm going to listen to all of my patients. As Jacqueline said, we all have implicit biases. So I pledge to take special care to listen closely to my Black, brown, and impoverished moms, to listen to their concerns, to take their pain seriously, to make sure that I'm dotting my I's and crossing my T's in the care that I provide them, and taking into account some of those barriers to care that maybe I don't experience, so it doesn't come to my mind immediately, but they experience every day of their lives. Next slide. Next slide, please, Emma. Thank you. All right, everybody. So our goal was to create discussion about the experiences of our patients and our fellow human beings. And we know that this is a difficult and really emotional topic. I feel pretty emotional after hearing Dr. Cunningham's story. I know that these can be hard conversations, but we really encourage you to think about these questions that I'm going to read out to you and think about how you would answer them yourself and how you talk to them, how you talk about them with your friends or your family, your coworkers, your program director, whoever in your life that you feel needs to have this conversation. So these questions that we've posed for you are, how do you think Black moms feel about these statistics and the outcomes? Can you think of any barriers to care that we didn't cover? Our list certainly wasn't all inclusive. How does your field of study or your major or your department impact the care of pregnant women? What can the medical community, that's me, Kiesha, and others, what can we do to address racial disparities in OBGYN care? And then what can other professions do to address this problem? It's not just medicine, there's multiple factors coming into play here, transportation, health insurance, the list goes on and on. So again, we encourage you to think about these things and start having those difficult conversations. Please feel free to drop any questions you have in the comment box or answer any of these points. We'd love to see and hear your thoughts. Thank you all.
Thank you guys for our speakers so much for joining us and educating us all on this really difficult and really important topic. We are going to go ahead and bring you some questions. Give me 1 second. Do you have any?
One of the questions that was asked was, what is the difference between a Black serving hospital and a Black hospital? Can you all address that, please?
So I mentioned about the barrier in my slide about the barriers to healthcare system level, how Black women are more likely to give birth at hospitals that serve predominantly Black populations. So when I was talking about that, I just mean hospitals that serve a population that is a majority Black. So hope that answered that. I don't remember saying a Black hospital, but Black serving hospital is what I meant by that.
Our next question is, do you know if Black women are taken as seriously when they report symptoms? So I guess as seriously as white women or other women of other races would be, which might lead them to be ignored or underserved.
So I don't have any statistics immediately on hand, but I do know that especially in OBGYN, I'm that field of medicine, there's a long history of Black women and brown women's pain not being taken as seriously. The so-called father of OBGYN, who really pioneered the field, was experimenting on Black and enslaved mothers. Oftentimes they didn't have any anesthesia. They were held down against their will. And that just really set a long-standing tradition of Black and brown women's pain not being taken as seriously as that of white women's. So while I don't have any statistics, I would imagine that, yes, once they report symptoms, still they're probably not taken as seriously.
Okay, I think that was all the questions that we saw in the chat. So thank you all. Oh, wait. Okay, another question. Just got another one in. How are these issues of implicit bias addressed in the medical student education?
Yeah, so we are third-year med students, and I think it was during our second year, we actually had a wonderful presentation delivered to us by Dr. Cunningham, who was our guest speaker tonight. So she walked us through so many statistics and really took her time taking us through the issue just to make everybody understand. And we actually have several of our classmates on the call tonight, which is just so wonderful and heartwarming to see that people want to contribute to this conversation and learn more.
We also had several talks given by some of our, like one of our deans at the Brady School of Medicine, Dr. Bright, we've had different discussions with him where we bring students in and we talk about disparities and we talk about how these disparities affect patients of color. And so, those are not required, but we are very, it's an open room to kind of talk about these issues. And we've had several of those, so that's another way that we kind of address those.
Yeah, and we had some cool also comments happening in some of the chat. Someone has said, many Black women also have barriers to care for their children simply because of shift work, which is also really important. So, sleeping during the day or things like that, not having access to some of the things that, are only open 9 to 5. Yeah. And I think, I believe that's all for questions that I see. I'll do one last pass through. Yeah. Okay. Yep, that's seems to be all for questions. Thank you all so much for putting on this presentation. It was wonderful. And thank you to the attendees for dealing with some of the technical issues and also, sitting tight for our first presentation. We really appreciate it. Thank you again, all of the presenters and Dr. Cunningham and Teresa. Thank you to everyone for being here. We're so excited. If you have further questions or comments or things that you're pondering, please do not hesitate to reach out to the Office of Equity and Diversity. Our OED office is amazing, and there's such wonderful people in the office that can really help with a lot of these things. I know it's hard sometimes for us to talk about them, and they're very good at facilitating those conversations and educating all of us on things. There's so many resources on their website, so please don't hesitate to reach out to them. And I think with that, we'll just go ahead and conclude the talk. Please come back next week. We have another amazing talk lined up from a dental student talking about her experience in her education. And we're just really, really excited to put on this series. Thank you all so much for joining us.
Thank you.
Thanks, everybody.